cut off, but we're going to resume where we were. What I had asked of you was, you're being a nurse practitioner versus a medical doctor that many of our residents might be accustomed to seeing in the office. You started to explain some of the differences. Well, you started with the similarities. And I think you went through the examination process, the scheduling process, the things that get covered would be really quite similar and not noticeably different. But what are some of the things that would be different, and how will we accomplish those for residents that are interested in utilizing you for primary care?
Well, I mean, the things that would be different, I suppose, you know, the only thing that really comes to mind that I can't do is if somebody wanted to elect to be enrolled in hospice, then you do need a physician to sign on for that. But apart from that, that's the only particular thing that I can think of outside of skilled nursing in the general primary care arena. You know, the particular insurance companies might have differences, but it's unlikely that if you're able to see one provider in the group, you're not able to see another, regardless of what their training is. So, you know, generally speaking, in the day-to-day, there isn't really much difference. The main difference is how we're trained. So Dr. DiNapoli obviously went to medical school, did a residency, and was trained in a model that looks at body systems and particular disease states, whereas I was originally trained as a nurse. And then I went on to do my master's to be a nurse practitioner. So my training is more of a kind of comprehensive and holistic training. So some people find a difference in the way that we practice because of that. But in terms of actual tasks and the ability to do that, there are really very few differences. None that I can see would be limiting to any of our residents here.
Right. And so, I mean, you obviously have now several years of experience working with, you know, the senior population, which is going to be the bulk of your you know, patients that you would see here. I know that we're going to work through some insurance issues. The vast majority of our residents have Medicare and AARP. There are some that have Medicare managed plans and some other things. So we can work through insurance verifications if a resident is interested in switching to you. We can work through the process of, you know, switching them from their existing primary care physician to another. Describe to me your approach to medicine. I mean, you described a little bit about your training as being more of a holistic approach. I've always gotten the impression from you that you really value person-centered care and not a focus on, you know, the body systems and the health systems as you just described. Would you characterize yourself in a way that describes someone that likes to provide care to the whole person?
I would think so. I think that, you know, especially as we get older, there are any number of different things that, you know, one could kind of follow with a specialist for. And the way that medicine has kind of gone in the last number of years, there's a specialist for everything. So oftentimes we don't have one practitioner that will manage all of your conditions or all of your medications. And sometimes that's good, and sometimes it's absolutely necessary. But there comes a point in life where maybe it's not, and maybe we don't need to have all of these appointments, and maybe we don't need to take all of these different medications. And so that is kind of my particular approach to things. Obviously, you know, anyone that wanted to come and see me, it doesn't mean that you can't see anybody else, of course. And I would never say to someone that they should stop seeing their specialist. I do work closely with other practices in the community to kind of provide a more comprehensive evaluation. But that being said, you know, if a person wanted to scale back and be less aggressive in terms of pursuing every medication and every, you know, lab test, then that's kind of what my approach is. Like, let's look at your quality of how many pills you're taking and how does that work for your life, and what is absolutely required, and maybe what can we reduce or eliminate.
Right. And that's something that you practice in skilled nursing as well now?
Mm-hmm. It is. Yeah. As we get older, the more likely we become to either have bad reactions to medications, have interactions between medications, and there are medications that work really well for lots of things, but are looking at a long-term benefit that are not necessarily appropriate, especially with somebody who is, well into their 90s, which our residents often are because they're in excellent health and they have amazing longevity. And that is something that, both Dr. Napoli and I both feel pretty strongly about, that if you don't need to be on all of these things, let's avoid a problem by eliminating what is not absolutely necessary.
Right. Now, I know sometimes in the skilled nursing setting, if somebody's a short-term rehabilitation stay, you're less likely typically to revise
Sure.
their medication regimen.
Mm-hmm.
But as they're potentially transitioning to being a long-term resident of skilled nursing and become totally within your care,
Mm-hmm.
I know that the approaches can be a little bit different. And then you might see that, gradual dose reduction or the either the elimination of certain medications. Is that about right?
Yeah. I mean, if somebody is only going to be with us for a couple of weeks, then, I'm not going to meet you and change all of your medicines. That's just not a good way to practice. But if we get to know each other over time and we can see, what kind of your plans are in terms of how you'd like to manage your care, and, what we see over time in terms of changes in things like your blood pressure or your lab values, then we develop a relationship, and that's where these sorts of changes come in.
Right. What about vaccines? The flu vaccine and other things like that. Would residents be able to access that in your office here if they were your patient?
Yeah, absolutely. Yeah.
Great.
We're working
Great.
on, of course, a way to kind of provide all of these services under one roof. And so hopefully over time, we'll be able to expand what we can provide.
Right. So just the physical description of the space for those that aren't envisioning it. I mean, it looks to me like a typical doctor's office. I mean, you don't have diagnostic equipment in there
Right.
per se, but you certainly have, an exam table. You've got all of the handheld pieces of equipment. I'm sure you have some of your own personal items. So they could expect to really have a full, typical medical exam that doesn't require diagnostic equipment in that space.
Right, right. And of course, if somebody needed to have blood work or x-rays or something like that, then it would work the way that it works through your regular doctor's office, where either you're sent a prescription to a lab or to an imaging center.
Right. Now, one thing that has actually developed, so many things have changed with COVID, but one thing that has happened is we have developed a relationship with a traveling lab for independent living residents that will come here and do blood draws.
Great.
With a prescription. So that's fantastic. So that could probably combine with a prescription from you. They could have that lab come and do their blood draw. So that could be a convenience.
Definitely.
I think about, cold weather and getting on a bus to go get your blood drawn. Much better to have it in your own home, right?
Yeah, exactly.
What about palliative care, hospice, comfort measures? What's your approach to embracing that kind of a practice?
I mean, so I actually have a subspecialty in palliative and end-of-life care, and I have worked doing palliative care in the hospital. I think that we all have to kind of embrace the fact that death is inevitable. So much of medicine today kind of pushes the idea that each problem can be fixed, and sometimes we lose sight of the fact that none of us are going to live forever. The way that I personally approach it is that it doesn't matter how much time you might have, as long as you can use that time in the way that you want to use it and be with the people that you want to be with. So having kind of a long-term view if somebody has a chronic illness and saying, you know, we don't know how long this might be, but we have some idea of what it might look like, and let's make plans so that it's not distressing and it's not, you know, a surprise, and that we have support and we have what we need, and your family has support as well. So for me, what we call advanced care planning is very important. And I think that it's something that absolutely belongs in primary care, because you have to have a relationship with a person in order to have these discussions. You know, it's not something that we like to just walk in and say, hi, it's nice to meet you, let's talk about what happens now. The ability to kind of look forward and the ability to kind of decide what you want your last days to look like, I think is something that people generally do want, even if it's not something that they like to think about all the time. So having things like palliative care services and having hospice, which of course is an actual separate entity, are important in anyone's care.
Good. And particularly, you know, for our resident population, many of our residents will face that, you know, and I think it's great to have a lot of different approaches in your toolkit. What else do you think might be interesting to residents to know, or things that we maybe haven't covered, if anything?
I think, you know, some of the questions that I've gotten, so, you know, as we said, right now, I'm planning to be in on Mondays, and hopefully over time we can expand the days and hours that someone is in the office. But at the moment, we're not really capable of doing what we would call like urgent visits on those other days. So if I'm in on a Monday and you're not feeling well, you know, and I have time, of course, I'm happy to see you, but unfortunately, we're not able to do that every day right now. And then there are, of course, things that it's unlikely we would be able to do in the future just because of the limitations of equipment. So things like if you had a cut that needed suturing, I probably couldn't do that right now, certainly not. And in the future, it's just a matter of having that sort of equipment. So not necessarily likely, but everyday things, you know, vaccines, absolutely. And then, you know, we'll see kind of what the interest is and where we can go with it. And hopefully we can provide more of these services so you don't have to go somewhere else, especially when it gets to be cold again.
Right. I mean, just so I mean, I'm sure you know this, but generally speaking, if our residents do experience a skin tear or cut that requires sutures, generally they're not going to their physician's office either now. Right. They're going typically to urgent care or to the hospital. Right. So that won't be so unusual.
No, not terribly different.
Yeah. So we can certainly work through that. And my, you know, one of my greatest dreams would be that this program expands and we have enough interest and can entice you to be here, you know, a couple days a week. You know, lots of people can start to see you, and really we can create a cohesive community health plan here at the community.
Yeah.
Well, I think we've sort of covered, I think, a lot of the you know, questions that have come up that I've heard. Again, as I said, we have some logistical things to work through. We have started to compile a list of those residents that are interested in switching. And I will work with the administrative folks at MAHV to figure out how we do that. But I'm excited about this, Rachel, and I hope that this is the beginning of you know, an expansive partnership.
I hope so too. I'm looking forward to it.
Great. Thank you.
Oh, thank you. I can't wait to see everyone.
That's right. Bye.
Bye.